grateful for you sharing your knowledge. Kathy's career started in a non-traditional way. She was 37 years old when she obtained her Associate of Science degree, and 47 when she completed the Baccalaureate Science in Nursing degree from Medical College of Georgia. I had no idea that you were even that old, Kathy.
I am.
She continued pursuing nursing, specifically to become a labor and delivery nurse and bestow upon her patients the kind and supportive treatment she received when she was in labor with her fourth child. She is now the maternal outreach educator at Phoebe Putney Memorial Hospital, the regional perinatal center for the southwest part of the state. Kathy also holds 2 certifications, one in inpatient obstetrics and the other one in electronic fetal monitoring from NCC. So thank you, Kathy, and it's all yours.
Thank you so much. I appreciate it. Thanks for allowing me to be with you guys today. I've never done a webinar, so if you feel a little tremble in my voice, forgive that. Thanks, DPH. Thanks, GaPQC and Georgia OBGYN Society for all you do for the moms and babies in our state. Next slide. Okay. Y'all know we are involved statewide with this AIM Collaborative as our GaPQC initiative. If this is your first time to join the monthly AIM Collaborative webinar, welcome. Glad you're here. Today we're going to be looking at a little part of the OB hemorrhage bundle, the risk assessment part. It's the second domain of the 4 domains that the AIM safety bundle directs for us to do. We all know that an ounce of prevention is worth a pound of cure. And being able to recognize the risk involved or what heightened risk will allow us to notice that moms are hemorrhaging, will allow us to intervene and more quickly and adequately help save her life, possibly. Just to recap, OB hemorrhage affects 2 to 5% of all births in the United States, and it's one of the top causes of maternal death. Failure to recognize that excessive blood loss during childbirth is a leading cause of maternal morbidity and mortality. It is sad. Women do die from hemorrhage, and mostly because of a lack of early and effective interventions. One of the states I was reading, in 90% of the cases of their maternal mortality, the causes led back to failure to identify the high-risk status. So risk assessment is really, really important. Next slide. Okay. You are looking at the page you've probably all seen if you're involved with AIM, and that's why you're on the call. This is just the list from the safety bundle. We're going to cue into that red oblong oval there, the first point on recognition and prevention, which is assessment of hemorrhage risk. How important is it that we recognize risk factors for hemorrhage? Well, I'll tell you, there are too many mamas whose lives depend on our recognition of those risks. Too many. So it is very important to be able to notice and recognize what the risks are. We don't want to miss the triggers or the risk factors. I think of that little saying, forewarned is forearmed. If we can recognize the risk, we are already ahead of the game to be able to intervene for them. Next slide, please. On the safety bundle, if you've read through it, you know that there are times or specific times to be alert to what those risk factors are. One of the first places we can begin to notice a risk factor is on the prenatal record, looking at a history. It may be, in one vein or another that will alert us to the risk. When we can recognize it, it allows for us to anticipate some kind of plan for that mom. There are lots of tools available for that assessment, and we're just going to look at a few of those samples in the course of this quick thumbnail sketch. So next slide, please. What does that prenatal risk tell us? The prenatal record, what does that record tell us if we're lucky enough to have one? Because we all know that not all our patients even see a prenatal care provider. So we may not have that record available, in which case we will rely on the patient's interview, the patient information. But that prenatal record can reveal to us what their history is, not just their prenatal labs, but their medical history. You know, does she have a scarred uterus? It could be a risk. Are there genetic or inherited disorders that she knows about that will alert us, something like von Willebrand's? Okay, next slide. I said we'd be looking at some samples of risk assessment tables. You know, a month or so ago, I did a Google search. I Googled postpartum hemorrhage risk assessment tool, and in less than 2 seconds, got 700,000 hits. So there is definitely a tool out there if you don't have one already. This 3 that are listed on this slide, one is from ACOG, Risk Assessment Table. One, the top right, from the A1 Postpartum Hemorrhage Project, and the bottom right, CMQCC, California Maternal Quality Care Collaborative, if you're not familiar with that. It's a vast body, a resource for us to use also. But no matter how many tools there are out there, or checklists or check boxes that, you know, it seems like we may be just jumping through a hoop checking off things, there is nothing, no amount of paperwork or electronic record work that could replace our clinical judgment. So it's always, always important to be sure that we stay, you know, clinically able to recognize what our moms are telling us or showing us. They might not even know it themselves. Always, always actively assess your patients or encourage your staff to do so. Next slide. So, can a patient go from low risk on admission to high risk after delivery? Why, yes, yes, they can. And that's why it's recommended that we minimally do 3 risk assessments. Now that, you know, the risk assessment is not a static item that we are only going to do on admission, pre-birth, and post-birth. But because of the nature of labor, we well know that moms their status can change rapidly. So we should be continually evaluating our patients for increased risk. Next slide. So this is a copy of the CMQCC risk assessment and the corresponding blood bank request with those risks. Being able to identify early, you know, this has corresponding blood bank requests with it. And it looks like it may be recommending that this is what we do. If we've got a medium risk mom, we're going to send type and screen. If we've got a high risk, we're going to go ahead and type and cross. And not, you know, low risk, maybe just a type and hold and not run that if we don't need it. But that's not actually what they're saying on this particular slide. The risk levels that mandate what pre-transfusion testing is indicated could be dependent on your facility. We all know that, you know, some places have the ability to just run a type and screen, and it's not expensive. They got everything in place to give us a quick turnaround. It might be that it's such a quick turnaround on our labs that we were not going to send for a type and screen unless they do have risk factors. It might be that every patient who comes into labor and delivery is going to get a type and screen because we don't have that much quick turnaround. And if we need the results of the type and screen, we need it done on admission rather than when, you know, when it's too late to, or not too late, but time consuming to wait on that. So facility dependent on the pre-transfusion testing strategy. Each place might need to, you know, analyze how well their facility is able to get the results of a type and screen. Okay, let's look at the next slide. not just the admission, pre-birth, and post-birth risk assessments. We, should be ongoing. Additional risk factors that could develop during labor include prolonged second stage, prolonged oxytocin use, active bleeding, chorioamnionitis, if the patient's on mag sulfate. None of these will exist before they get to us, but could develop during labor. So that might heighten that risk. During the third stage of labor and postpartum risk for hemorrhage, did we have to use a vacuum or forceps to assist with this delivery? Was there a shoulder stocia with this delivery? Did we have to do a C-section? Were there retained placental fragments? All of these things will heighten the risk for hemorrhage. Next slide. You'll recognize the next 6 slides if your hospital participated in the A1 postpartum hemorrhage project a few years ago. But if you didn't, we'll just review these. I'm talking, been referencing or talking about low, medium, or high risk, and these are just some examples of what will put our patient in that specific risk category. So a low-risk patient would have no previous uterine incision, singleton pregnancy, less than 4 or less previous vaginal births with no known bleeding disorder and no prior history of hemorrhage. If we're going to heighten our surveillance or think, what is medium risk? We'll look at this category. When they show up to us in the hospital and they think they're in labor, or they actually are in labor, or if we have to induce them, that puts them at a medium risk if we have to induce them. Multiple gestation, more than 4 previous vaginal births, prior C-section or uterine incision, myomectomy or some other uterine incision, large uterine fibroids, history of hemorrhage, a first-degree relative who experienced hemorrhage. That would be a parent, sibling, or a child. Chorioamnionitis, fetal demise, estimated fetal weight greater than 4 kilograms, morbid obesity with a BMI greater than 35, or polyhydramnios. Any 2 medium risk factors will advance that patient to a high-risk status. And you see here what the high-risk status are on the admission risk assessment. Active bleeding more than just the bloody show. Suspected placenta accreta, percreta, or increta. Placenta previa, low-lying placenta, a known coagulopathy. If their hematocrit is less than 30, and other risk factors. History of more than 1 hemorrhage, or if their platelets are less than 100,000. Okay, next slide. If from the admission risk assessment we determine our patient to be low risk, medium risk, or high risk, these are the corresponding interventions we may anticipate. So you'd want to get a type and screen. If it's a high risk, you probably want to go ahead and type and cross. Notify appropriate personnel, such as the provider, the anesthesia provider, maybe even the blood bank. Of course, you want to let your charge nurse know, maybe the midwife or clinical nurse specialist on duty. So if it's high risk, you will notify the appropriate personnel and consider delivering at a facility with the appropriate level of care capable of managing a high-risk mom if she is stable enough to transport. Next slide. Now, pre-birth risk assessment. This is supposed to be done within 30 to 60 minutes prior to delivering. And when we did the A1 postpartum hemorrhage project a few years ago and said, okay, you're going to be doing the admission risk assessment and a pre-birth risk assessment, it's had a little bit of, how should I say this delicately, eye rolling, maybe? Like, right, how do we know? They're either on the perineum. We think they're going to be here in a few minutes. Fortunately, folks push for maybe, a couple of pushes to maybe an hour or so. Our staff was a little bewildered as to how they were going to guess this 30 to 60 minute pre-birth risk assessment. But we all know it can be done, and sometimes if they deliver so quickly that we don't get that in, it may be a documentation that is a little bit of a late entry. So some things that change from admission to pre-birth may be we had to augment labor with oxytocin, or if their labor just went on and on for more than, normal time frame for us, or if they developed a temperature. What if we had to put them on MAG? That would bump them up into a higher risk category. And the high risk for the pre-birth, when they began bleeding more, and we suspect abruption. Okay, next slide. This is the anticipatory interventions for the pre-birth risk assessment. I know we'll talk about quantifying blood loss at a different day, but ensuring that we've got a way to know how much our moms are bleeding. Even in that pre-birth assessment, if we've got availability of calibrated drapes, scales to weigh, and to measure that blood loss for every birth, you can review hemorrhage protocol, review the lab work, notify the provider and charge nurse. These are the things that we would correspond to those medium and high risk at the pre-birth assessment. Next slide. And post-birth risk assessment, we would include the admission and pre-birth factors, kind of add on to those with this. They remain low risk throughout their labor and delivery if they never have one of those risks. But does that relieve us of our assessment skills and the red flags that may rise? No. So we want to be sure, to always be in tune to what's going on with the patient. That post-birth risk assessment within 60 minutes after birth, we may find that we had to do an operative vag delivery.
The more risk.
Third or fourth degree perineal laceration, C-section, precipitous delivery. Now, precipitous delivery, there's a difference in the imminent delivery and precipitous delivery. Precipitous delivery is from the very start of labor to delivery in 3 hours or less. Just because they come to us about ready to deliver and deliver within a pretty quick time frame doesn't necessarily mean it's precipitous delivery. And shoulder dystocia. But any 2 or more medium risk will automatically put that patient at the high risk for hemorrhage. So we, again, note active bleeding, difficult placental extraction, concealed abruption, even uterine inversion will put that patient at high risk for bleeding. Next slide. So anticipatory interventions for a post-birth risk assessment. A high-risk patient may need intervention that we weren't aware of until after delivery. So we want to be sure that IV stays patent. If she's high risk, we may even need to insert that second large bore IV. Ensure immediate availability of uterotonics and the supplies needed. Ensure hemorrhage supplies or a cart are near the room. You'll know that risk. Get help and get the cart in the room and at the bedside, and be sure your provider is available and there. Consider notifying the team to prep for OR in case they need to do some surgery to stop that hemorrhage. I don't know if interventional radiology is a part or is available at the facilities. That's where interventional radiology would go to the OR and maybe do some artery embolization or pelvic arteriography and embolization. All those some anticipatory interventions for post-birth assessment. Okay, next slide. So from the CMQCC toolkit, recommendations are as follows. Do an initial risk factor identification during the prenatal period. If we are able and have access to the prenatal record, that's the way we in our hospital setting would be able to do it. Document findings in the record and make sure that when we have access when they're admitted to labor and delivery, that we'll be able to review that prenatal record. Risk factors should be reviewed from the prenatal records upon admission to labor and delivery, and the patient is assigned a risk category upon admission. Assessment of risk factors may change during the course of labor and should be performed at least once a shift until time of delivery. And it may be that they need to be performed more often as the patient's status might change. The next assessment should occur at the time of the delivery and any modifications to the plan of care made based on their risk category. The final assessment should occur during the postpartum period for the first 24 hours, not just that post-delivery, post-birth assessment within 60 minutes of delivery, but continue to assess for the first 24 hours, at least once a shift. Assessments can be done more frequently as the patient conditions may change during the course of stay. Okay, next slide. Okay, I'm not going to talk over these. This is with permission. A1 allowed me to put these up here. Those last 6 slides, well, not the last one, but the ones with the admission, pre-birth, and post-birth assessment. This is the A1 form. It's got the anticipatory interventions listed on the same page. So go ahead to the next slide. This is the admission slide. This is the pre-birth, what it looks like from the A1, and then the next slide is the post-birth. So I kind of talked through those on the other slides that we saw. A1 just makes it look really good. So next slide. This is a screenshot of our electronic documentation. We have the hemorrhage risk on admission, pre-birth, and post-birth. Next slide. This is a drop-down when we open up the pre-birth. You can see the different boxes that can be checked off for low risk, medium risk, and high risk in our electronic documentation. You see, it really doesn't matter what electronic documentation record you use. I know everybody's got, we use Meditech. I know Epic is out there, and there's lots more. Having your risk assessment built into that electronic documentation, it's part of what we have to do. I'm that old person, with 14 grandchildren now. So having the electronic record for me is not what I've had most of my nursing life. We did it on paper, but in the electronic record, it also offers us a glimpse of a checkbox system so that, we need to be looking for what's in front of us. It could help us get in the habit of constantly assessing our patients. The A1 has a license, there's a version from A1, version 1.1 of the postpartum hemorrhage risk assessment that can be I know some electronic systems have, I don't know if you buy them or what you exactly do with them to get them in your system. So they're out there, and they can be worked in your record if you don't already have the risk assessments built in. Okay. Let me see. The copy and paste that's on the screen now is that 1.0. So there is a newer version out there. A1's Postpartum Hemorrhage Online Education, part of their OB Patient Safety Program. Contact them if you're interested in having it copied onto yours. Okay, next slide. It's just another snippet of the electronic medical record with the post-birth assessment. You can see the same items that we talked through on previous slides are on that. Okay, next slide. Okay, who are the stakeholders? All of us, me, myself, and I, and you, yourself, and y'all. We are all here working together to improve the care and the outcomes of our moms and babies. And I just want to slide this in here. If y'all did not see the USA Today article, Deadly Delivery, in the July 26, 2018 version, pull it up and read it. One thing that keeps sticking out in my mind from that article was that it was found out we know what is best practice and we know what to do. We are just not doing it, doctors and nurses. So, I'm, as a stakeholder, as an interested party, as someone who loves the outcomes to be better, and I just love my job, and I want our moms and babies in the state to have the best. So, if you know the right thing and don't do it, what is that? What is it? All right, off the soapbox now, Lauren. Thank you all for listening, for tuning in, for caring. So, just keep the passion up, and thanks for being a part of the effort to prevent maternal mortality and morbidity in this great state of ours. Thanks.
Thank you, Kathy. That was excellent. Thank you again for the resources that you provided.